Hi, good morning, everyone. How are you doing?
Good morning.
Good morning.
Good morning. See, we are only few people, as I said before. You can have your the microphone on, so that whenever you want to say something, you can just speak out, and I can hear you. Okay, so all of us are here now. So now let's start. I want to start with any question that you may have from the last two sessions that we had. Do you have any question? You see, one of our our professors, he said, when the students say we don't have any question, that can be suspicious. You see, the one thing, one of that is that they understood everything, or they didn't understand anything. So I wonder, I hope you all are very smart graduate students, so you are matured students, so hopefully you understood everything. That's my hope. you know so far, we talked about how an external stimulus is converted into a nerve action potential, right? That is so far our focus. So we just wanted to see, and then we talk about the receptors, how the receptors convert those different form of energy. Either it can be mechanical, or chemical, thermal, or electromagnetic, whatever the type of energy is, that is converted to an action potential, which a nerve can carry as a signal. So that was the main focus of the receptors. So that was the first part of our sensory system. Any stimulus is internal or external, converted to an action potential that travels through the nerve, and that carries that signal all the way to the sensory area of the brain, where the brain can interpret the signal and give us a conscious sensation. Now, so we cover up to the receptors, where the signals, the stimulus are converted to an action potential. Now we want to know today. My goal will be how this action potential travel from the receptor through its sensory nerve all the way to the sensory area of the brain. So that is the goal for today. That is the goal we want to achieve today. Now, see, one thing, let me remind you one more time. This class, with the graduate student, we don't want to, the deliver the lectures, or do the class in a way that I am just teaching something. That is not what I want to do. You are now matured enough, and you have good understanding. You are graduate students. I want to keep it more like the discussion, a topic I read, you also read, and then we see, if we can, if we any group, actually, if you have any problem, see if I can help you out with the understanding, or if my understanding is not very clear on something, see if you can help me out with your experience, or with your expertise. So having said that, now, before we said, all the signals, all stimulus on a nerve is converted to an action potential by a receptor. Now, as I said, today I will be talking about how this action potential travel all the way to the brain. Now, before going into the pathway, the sensory pathways that carry the signal from the receptor all the way to the brain, let's go back a little bit and see if we have the basic understanding, good understanding of the concept that we are talking about. The first thing is, we said cells. I think I briefly mentioned about membrane potential. Do you have any idea what is a membrane potential? Tell me. I would, two of you have definitely good neuroscience background. So can any of you tell me a little bit about the membrane potential and what it is, and just in your own words, you know. Anyone want to volunteer something? No volunteers?
The membrane
Oh, go
potential
ahead. Go
is
ahead.
It's the resting electrical potential of the cell based upon the ions inside and outside of the cell. And
Mhm.
that's normally like with potassium and calcium and chloride.
Good. Potassium, you said potassium, calcium, and chloride, right? So you omitted one very important ion, that is sodium, actually. That will be very important in membrane protection. But wonderful, that is what we want to know. Basically, those who don't have neuro background, let me tell you, just in a layman's term, the basic term, right? Not everybody, not all of you will use this thing in your research or in your PhD studies. But once you said I took a basic neuroscience course, you are supposed to know those basics, actually. So membrane potential is something, if we take a cell, okay, experimentally, if we take a cell and we put one electrode inside the cell and we place a reference electrode outside the cell, and then we compare the electrical current between those two sides, outside the cell and inside the cell, we will find out that inside of the cell is negative compared to outside. And how negative it is, in most of the cases, it varies between minus 70 to minus 90 millivolt. What does it mean again? It means the inside of the cell is about minus 90 millivolt negative compared to the outside of the cell. So cells in our body, if you think in a way that our body, the cells in our body, they are suspended in the extracellular fluid, right? So this is the difference between the intercellular fluid and extracellular fluid. So we say, we just in a simple term, we say cells are a bag of potassium floating in the sea of sodium, which means outside your cell, it's all rich in sodium, but inside the cell, it is rich in potassium. So these are the information you definitely need to know. You don't have to memorize exactly how many millivolts. Say like for potassium, we say outside the cell in extracellular fluid, it is about 4 milliequivalent, and inside the cell is 140 milliequivalent. So you can see how much potassium is loaded inside the cell. Just exactly opposite is true for sodium. If you look at sodium, outside the cell will be about 150 milliequivalent, inside the cell will be about 5 milliequivalent. So you see the vast quantity of very high concentration of sodium outside the cell compared to inside, right? Now, we say about the cell membrane, we say cell membrane is a selective barrier. That is the reason you have more sodium outside, less sodium inside, more potassium inside, less potassium outside, because cell membrane is just not like a structure that everything can move freely. It acts as a selective barrier. Okay. Now, a few things that the very basic information that we need to know why, then the question comes, why inside the cell is negative? Who is doing it, right? Now, one thing you all have to remember, whether you do anything in neuroscience related or not, that inside the cell, on the cell membrane, you see our cells have nucleus, right? The nucleus produce proteins, they have genes to produce a certain kind of protein. So one kind of protein is called sodium potassium ATPase, sodium potassium pump. Okay, so every active cell, every living cell has sodium potassium pump on their membrane. Now, what does this pump do? This pump, so it's called sodium potassium pump. So from its name, we know that it will pump sodium and potassium across the cell membrane, right? Now, which direction, when the pump operates, which direction it will pump the ion? When this one operates, it pump the sodium out of the cell and it pump potassium inside the cell. Okay, so sodium potassium pump, we are talking about the sodium potassium pump, you know acting on the cell membrane. And then the second information we need to know is that this pump will pump sodium and across the membrane. It will pump sodium out and pump sodium, the same pump, and then pump potassium in. Now, every time that pumps work, what it does is that it pumps 3 sodium out and 2 potassium in. Okay, so if this pump keep operating, Can you tell me what will happen to the cell inside of the cell? Because you see the pump is pumping 3 sodium out and pumping in 2 potassium inside the cell. So every time this pump works, what will happen to the charge inside the cell? The cell will, if the pump keep operating, this inside the cell will be negative or positive, because you are losing 3 positive in exchange of 2. So cell inside the cell, the net effect will be inside the cell will lose positive charge, right? Like cations. So as the pump keep operating, it will create negativity inside the cell, because negative ions are not moving, they are inside. And now you are pumping 3 positive side, forget about sodium, potassium. You are pumping 3 positive out, you are bringing 2 positive in. So every time the pump works, you are losing 1 positive inside, right? So this, as this pump operates, this, you see, this pump is an absolutely important thing. While you are even sleeping, or you are lying down or sitting on a couch enjoying a movie, 25% of your energy expenditure of your body is used for to operate this pump. So this pump utilize about 25% of our resting energy. So you can imagine how important or how valuable this pump is. Now, as this pump operates, this will create some sort of negativity inside the cell, because it's pumping more positive out than taking more positive in, right? So that's why, because every time this pump works, we call it, if it pump equal number of positive charge in and out of the cell, we would call this pump an electroneutral pump, because if the pump operates, it doesn't change the electricity in the cell. But because it is doing 3 out, 2 in, so we will call this pump a electrogenic pump. As long as the more this pump operates, the more negativity will be created inside the cell. That's why we don't call it, it cannot be electroneutral. By nature, it is it's electrogenic pump. Okay, so this pump, as this pump operates, it creates a negativity of -5 millivolt inside the cell. But we say the resting membrane potential is -90, right? -70 to -90. So where is the rest of the negative charge coming? Excuse me. So the cell membrane have channels for, we call them leak channels. They have channels for moving potassium, and they have channels for moving sodium. Okay, normally on a cell is way more permeable to potassium ion than a sodium ion. So under normal circumstances, more potassium will go out of the cell, but sodium cannot move, because cell membrane doesn't let sodium. If the cell membrane allows sodium to move, which direction sodium will move? Inside the cell or go outside the cell? Tell me. This one is important. Who can tell me? We said we have much more sodium outside than inside. And I said, if the cell membrane allows sodium to move, which direction sodium will move? If you think of concentration gradient, where is more sodium? Outside. Where is less sodium? Inside. So concentration gradient will drive sodium from outside to the inside, right? But unfortunately, cell membrane doesn't allow sodium to go in. Sodium are not allowed to go in. But cell membrane allow potassium to move out. Now, potassium is more inside the cell and less outside. So if cell membrane allow potassium to go out, which direction potassium will go? Potassium will go from inside to the outside, because inside you have more potassium, outside is less. So along the concentration gradient, potassium will move from inside of the cell to the outside of the cell, right? Okay, so if you understand that much, it's good. So we have the basics now. Now there is a formula to calculate, if you allow potassium to go in and out of the cell, there will be a situation. So there are 2 different forces. Let me tell you a little bit more. 2 forces. One is concentration gradient, which will drive potassium from inside of the cell to the outside, because concentration is much less. You see, along the concentration, when we say along concentration gradient, what do we mean? We mean things will move from higher concentration towards the lower concentration, right? So for the potassium, which direction is concentration gradient? From inside to the outside, right? Because you have more potassium inside. So potassium will move from inside to the outside. Okay. But there is another force as well, which is operating on the cell membrane, that is the electrical potential. The inside of the cell is negative. So when the potassium move out of the cell, that will create more negativity inside, right? Because you are losing more positive ion in terms of, in the form of potassium. So cell will try to resist it. So your electrical potential will pull potassium inside the cell, and your concentration gradient will try to push potassium out of the cell. Now, normally, at a certain condition, they come to an equilibrium where no potassium, net movement of potassium stops. So, if we calculate that, with a formula called Nernst equation. So you don't have to remember that. But if we apply that equation to calculate the membrane at which, when there will be no net movement of potassium, that is called equilibrium potential for potassium. That will be achieved when inside the cell become minus 85 millivolt. Until inside the cell become minus 85, potassium will keep moving outside the cell through these leak channels. They will be just moving along the concentration gradient. But when inside the cell become minus 85, no net movement of it, reaches an equilibrium. Now there is the equilibrium between the inward force and outward force. What is the inward force? The membrane potential. What is the outward force? It is the concentration gradient. Now at certain level, it will come to a point. That point we call it equilibrium potential for potassium, which means potassium concentration inside and outside of the cell reached an equilibrium where no net movement of potassium will take place. So what is that number? It will not reach equilibrium potential until the inside of the cell become minus 85 millivolt. Okay. Now, so we are done with sodium potassium pump. We are done with potassium leak channels. How long the leak channels will allow potassium to move. Now, if you look at a cell which is permeable to sodium, which direction sodium will move? Sodium definitely will move from the outside to the inside, because on the outside you have a lot of sodium, inside you have very little sodium. The sodium will start moving inside. Now, again, like potassium, there will be a situation, we call it equilibrium potential for sodium. At that point, no net movement of sodium will take place. So, and when it will happen? It will happen when the inside of the cell become 60 millivolt positive. Okay. Now, equilibrium potential for sodium is plus 60 inside. Equilibrium potential for potassium is minus 85. Okay. Now, what is our resting membrane potential? We say resting membrane potential is, just take an example of a large nerve fiber, it is about minus 90. So, is it close to sodium equilibrium potential, or it is close to potassium equilibrium potential? Our resting membrane potential. You have to speak out. Say something.
Potassium.
Huh?
Potassium.
Good. Potassium. It's just simple, right? Potassium, because potassium's equilibrium potential is minus 85 and cell is minus 90. And if you look at with the sodium equilibrium potential, which is plus 65, which is way off. So our resting membrane potential is much closer to the potassium equilibrium potential. Okay, which means our resting membrane potential is contributed in terms of electricity mainly by the potassium leak channels. The sodium has very little contribution in the development of resting membrane potential. But we start the discussion with the sodium potassium pump, right? Sodium potassium pump is contributing only 5 millivolt, minus 5. Potassium is contributing minus 85. But even though in terms of number, potassium contribution looks apparently high, but most important here is sodium potassium pump, because if you allow the leak channels to allow all potassium will move outside the cell. So the pump, the mechanism that keep potassium high inside, keep high concentration of potassium inside and high concentration of sodium outside, is by the operation of sodium potassium pump. And that is an active pump which require energy. Okay. So that's how the membrane potential is formed, right? So if somebody say what is resting membrane potential, we can say this is the potential difference between inside and outside of the cell at rest, right? So where will you get resting membrane potential? Almost all cells of the body has a resting membrane potential, right? Now the next term, we say we want to be familiar with two terms. One is resting membrane potential. The other one is action potential. So now we know about resting membrane potential. What is action potential? When an excitable tissue is stimulated, there is a rapid change in their membrane polarity. This rapid change in membrane polarity is called action potential. Now, we said in terms of resting membrane potential, we say almost all cell will have resting membrane potential. But for action potential, it is the excitable cells actually. So what is the most important example of excitable cell in our body? These are nerve cells and the muscle cells. All type of muscles, skeletal muscle, smooth muscle, cardiac muscle, they are all excitable. If you stimulate them, they can generate an action potential. If you stimulate a nerve, they can generate action potential, which means these are excitable tissue. Okay. Now, we know how how the resting membrane potential is maintained. We say two important factors. One is sodium potassium pump and potassium leak channels. Okay, these are the two most important contributors in the formation of resting membrane potential. Now, action potential is a potential difference. So when you say, like we said, whenever you apply a stimulus, say I touch my tip of my finger, right? So what it does is that this touch, this is a mechanical stimulus, right? So this mechanical stimulus, what it does, it causes some change in the local sodium channels. These are not voltage gated channels, so they are very different. So when those channels open, some sodium will get inside the cell because of the stimulus, in response of the stimulus. So if some sodium get inside the cell, which direction the cell's potential will move? It will move towards positive or it will move towards negative? Sodium is going in. Normally, okay. So if we say the resting membrane potential of that particular cell is minus 90, okay, and we pump some sodium inside the cell, what will happen to the membrane potential? It will go to, you don't have to come up with a number, it will go towards positive or it will go towards negative, more negative.
More positive.
Wonderful. Yeah, it will go positive because we are pumping sodium in. So why sodium is going in? Because you stimulate it. You apply a stimulus. In response to the stimulus, some sodium channels, these are very little, some sodium went in. That will create a small potential, but that will be a positive. That will be in the positive direction. If the cell is minus 90, it will maybe, depending on stimulus, maybe from minus 90, it will go to minus 85. From minus 90 to minus 85 is a movement in the positive direction, right? Okay. Now, every cell has a threshold for excitation. Okay. It will not create an action potential until it reaches the threshold. Okay. So now you apply a stimulus and then cell membrane, resting membrane potential from minus 90 become minus 85. But maybe the threshold for excitation is 80. So minus 85, still you are not there yet, right? But if you apply another one, it go on top of this one, added, and then maybe by 2-3 repeated stimulus, you reaches the point of minus 80. Minus 80 is, we said, threshold. You said these are arbitrary number I'm talking about. So because different cell have different threshold, right? But if your stimulus, the number of sodium going in reaches the threshold for excitation, the cell will form a full-fledged action potential. Okay. Now, action potential means we said action potential has different phases, right? When the cell loses its negativity, we call it depolarization. Normally, cell is polarized, negatively charged. So when sodium keep going in, we call it depolarization, right? Now, depolarization doesn't occur it's very few milliseconds, and then sodium channels are now. Okay, to one thing. So initially, small positive potential that took place because of the mechanical sodium channels, right? These are mechanical channels. But when the cell reaches its threshold for excitation, now at that point, voltage gated sodium channels open up. That will cause rush of sodium ion inside the cell, and within seconds, within milliseconds, actually, I should not say second is too long. Within millisecond, cell will completely lose its polarity. From -90, cell will go to 0, or say maybe +10, depending on which cell you are talking about. So it will completely lose its polarity. That phase we call depolarization. Now, within few milliseconds, the sodium channel, voltage gated sodium channel that opened up, that will close. And at the same time, potassium channel will open up. So when the potassium channel will open up, potassium will start going out of the cell, rush out of the cell. So when the potassium will start going out of the cell, now because of potassium moving out of the cell, which direction membrane potential will go? In negative or in positive?
Negative.
It will go towards the negative direction, because now I am losing, so losing positive, right? Which means if you lose 10 positive, it will go towards 10 negative, right? Okay, so now potassium will go out, and then your membrane potential will return to its resting membrane potential. We call it a repolarization. Initially, a cell was polarized, and then you lose the polarity, we call depolarization, and then it regain its polarity, we call it repolarization. There is a small segment there, it goes beyond the resting membrane potential, we call hyperpolarization, but we don't want to get into that. Okay, so now, so how this action potential was generated? Initially, it was a small influx of sodium. And then when the cell reaches its threshold, then there was a rapid influx of sodium through the voltage gated sodium channel. And then after that initial depolarization, cell quickly return to their resting membrane again. How? This time ionic movement. Which ion is moving now? Potassium is moving. Which direction it's moving? It's moving up. Because if potassium all start coming in, cell will become much more positive, right? Now we are losing potassium, so cell will return to their resting membrane potential, right? So sodium in, depolarization, potassium out, repolarization, right? And this in and out, rapid in and out, will take place through the voltage gated channels for both cases, sodium and potassium, for both of them. But initially, the receptor potential or generator potential that you see at the beginning, to reach the threshold, that is called a generator potential. Now, what is the difference between generator potential and action potential? Generator potential is graded, right? First time you get 5, you get another 5, you get another 10, something like that. It's graded. But action potential is not graded. Either it will make a full action potential, or it will not do anything. It's all or none principle. Either there will be full size action potential, or there will be nothing. That is one thing. One is graded membrane generator potential. Other one is not graded. It's all or none. And generator potential is non-propagating. This signal doesn't propagate. It stays there. But action potential propagates. Once you can create an action potential in the nerve, it goes all the way to the end of the nerve. Okay, and then over there, there is another system. We have the synaptic transmission or neuromuscular junction. But at least one action potential generated in a nerve, it will transmit to the other end of the nerve without any problem, because action potentials are propagated potentials. Okay, so this is something very basic. I thought you need to understand. Now, Let me remind you one thing. Don't worry about this part. This is just for your understanding. You just cannot leave, complete a basic neuroscience course and then somebody asks you what is action potential. You say that was not taught in the class. That will be a shame on us, actually. So that's not something we want to do. But you will not be tested on this. I will not test you on these things. This is just for your understanding. I know you have a good understanding about the things, but it's my responsibility to remind you. Reminder is good, actually. No matter how expert you are on membrane potential and resting membrane potential and action potential, it's always good. A reminder is always good. So I know I'm not doing something new, but I'm just reminding you, actually, just trying to refresh your memory so that it come to your mind again. So what was those things? So these are basic things, the basic concept that we need to know. Now, let me share my screen. If you guys are okay, I will share my screen and I will show you a few slides where I will talk about this the how this signal transmit. Okay, so I'm sharing my desktop. This one is here. Okay. Okay. So here are some definitions. You don't have to worry about them. Okay. Now, so do you see my pointer? All of you can see? Good. So you see, once a signal is converted, now we know about rest action potential, right? So when an action potential is generated in the nerve, it carries all the way to the other end of the nerve, right? Now, eventually, what is our goal? We want to send the signal that is generated in the receptor, we want to send it all the way to the brain, where brain can analyze the information and can give us a conscious sensation, right? Which means all signals that are generated in the peripheral parts of the body, they need to, how they will go to the center, how they will go to the brain, they will enter the spinal cord, and then spinal cord will take this information all the way to the brain. Now, as the nerve fibers are coming, entering the spinal cord, they will occupy a very specific area of the spinal cord, depending on what type of fiber you are carrying, what type of sensation you are carrying. That's how they are distributed in the spinal cord. And when they come to the spinal cord, they form a bundle of fiber. They go up as a bundle of fiber, okay? A bundle of fiber carrying similar type of information. Now we are talking about sensory information. We are not talking about motor. Don't worry about the red things. We will be talking about only sensory. Okay. Now the nerve bundle that they form, we call them nerve tracts or fasciculus. Okay. Now, so we talk about all type of sensation. Let me start with one, which is the somatic sensation. We divide them into two groups. On one group, they contain the touch, the position, a touch and position sensation, right? And proprioceptive sensation. Those are one set. And the other set will carry pain, temperature, and crude touch. Okay? Crude touch, pain, temperature, they are carried by another group. So if we separate the general sensation, somatic sensation into two groups, one group will have fine touch and the position sense, and like proprioceptive sensations, right? Position sense of the body. Now, and then other group will carry pain, touch, not fine touch, it's a crude touch, and pain and temperature. So these are the two groups. Now let's start with the group one. Group one will carry fine touch, position sensations, and proprioceptive information. Now, all these information, when they arrive in the spinal cord, are you familiar with the cross section of a spinal cord? Are you guys okay with that? No? Uh-oh. Then let me draw something. Let me see if I can draw something. I don't know whether it will let me draw something here. Let me see. Pen. If I have a, I can do a pen, right? If I do a, Okay, let me have a red pen. Okay, so if you make a cross section around the spinal cord, you will see something like this. Oh, okay, 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 okay. Oh, my drawing is pretty bad. Okay, so this is the whole section, right? On the center, there will be an opening called central canal for the CSF, right? And then, so this is the whole spinal cord, right? Now, in the spinal cord, we said there are gray matter and white matter, right? When we say white matter, we mean these are nerve fibers. And when we say gray matter, we mean these are nerve cell bodies. Do you remember for the neuron, we say neuron has two parts. One is cell body and the processes. The processes are axons. They are called nerve fibers. And the cell body, do you remember we talk about dorsal root ganglia? Dorsal root ganglia was cell body, collection of cell body. And do you remember we say two things? We said collection of nerve cell body inside the central nervous system is called nucleus, and collection of cell body outside the central nervous system is called ganglia. That's why we say dorsal root ganglia, collection of cell body. But in spinal cord, because this is a part of central nervous system, we call it nucleus, right? Now, where are the gray matters located? So gray matters will be something like this. So like so these are cell bodies, okay? So it will be something like that. Okay, something like this. Okay, so this part is the cell body, and this part is nerve fiber. Okay, these are nerve fibers, and this is somehow H-shaped thing here or cross-shaped thing. This we call it gray matter. Gray matter means these areas contain cell bodies, and these are all nerve fibers. So when the nerve fibers will occupy these areas and cell bodies will occupy these areas. But when a nerve, coming from outside, if they want to synapse, they have to synapse here because they have to synapse with the cell body. Okay. Okay. Now, so so when all this sensation, we said we are dealing with three sensation. We're dealing with touch, proprioception, and position sensation. When these fibers, so okay, so let me draw a. See the nerve is coming out in, right, carrying signal. So it will have a dorsal root ganglia here. Okay. So this nerve cell body is here. This is the process, right? So sensory signal is traveling through this process. Okay. And what is the end of this nerve fiber? This nerve fiber will enter the spinal cord and it will enter here. Now, this is the back of the spinal cord. This is the front of the spinal cord. That's why we call it. I'm pretty sure you are familiar with the term called dorsal. So when we say dorsal, we mean back, right? When we say ventral, we mean something in the front. And lateral means on the side. And midline is the midline, right? So this is midline. This is lateral. This is lateral. This is dorsal. This is ventral, right? Now, if we divide it into two equal halves, okay, okay, two halves, right? So sensation from this side, they will enter the spinal cord and they will occupy this area. Which column is it? Dorsal column, right? Dorsal column of the spinal cord. And there are two horns here. One, this is called dorsal horn. This is called ventral horn. Horns are gray matter, right? And the columns are nerve fiber white matter. Okay. So these fibers, the first group of sensations, touch and position, they will occupy the dorsal column. And then they will start going up with the spinal cord, right? They will start going up with the spinal cord. Okay. Now, you see here, if I divide it into two, we are just dealing with one half now. We are dealing with one half. So the sensation from this side will occupy this area, this area. So this is the dorsal column, right? Dorsal column. And the second group, which will carry pain, touch, and temperature, they will occupy two areas. Either they will be here or they will be here. Okay. So which region is this one of the white column? Lateral, right? Lateral white column. This is the ventral white column. Now, If it is a touch, if it is a pain and temperature, they will come here. They will occupy this area of the spinal cord. But if it is a crude touch, that will come here. Okay, so which column they will occupy? They either occupy lateral column of the spinal cord if they are pain and temperature. If it is carrying crude touch, it will not occupy the lateral area, it will occupy actually the ventral area or anterior area. That's why these tracts we call lateral spinothalamic tract. I will talk about that later. Lateral spinothalamic, this one is anterior spinothalamic. All I want you to understand here is the lateral and anterior. Why we call it lateral? Because that tract, the fibers are positioned in the lateral white column, right? And these are called anterior spinothalamic. Why? Or anterior or ventral, they are same. Why they are called anterior? Because they are located in the anterior white column. Why this one is called the dorsal column system? Because these fibers are occupying the dorsal column. Did you get this much? Okay, good. Now, and then now look at these are the gray matter, right? This is the gray matter. Now look at the gray matter is divided into laminas. The lamina 1, lamina 2, lamina 3, lamina 4, 5, 6, up to lamina 8, 9, right? They're different, they're divided into different laminas, not only instead of saying, oh, one more thing. So this area of the horn, this contain motor neuron, the sensory neuron, and this area contain motor neuron. So this is ventral. Ventral horn is for motor neurons and dorsal horn is for sensory neurons, right? So that's how they are arranged. Now, let me go, move forward. And then if you have any question from any areas, I can always come back. That's not a problem. Now, look at when the fibers enter the spinal cord, they are positioned in a very specific way. Okay, we call it a somatotropic map or spatial orientation of the fibers. Now we see this area of the spinal cord will have sensory fibers. This is one half, right? This is the other half. So this half will have the fibers, all fibers carrying fine touch and position sense. They will all come here and occupy this dorsal column of the spinal cord. Now, how they're distributed, you see the fiber coming from the sacral area. Sacral area means lower part of the body. They will be most medial. This is midline, right? This is midline. So they are most medial, and lateral to them will be lumbar fibers, one step up. And then thoracic fiber is from the chest area. They will be there. Then cervical will be most lateral. If you think of spinal cord, if you think of a spinal cord in the lower part of the body, there is no cervical fiber there, right? So initially the fibers from lower part of the body enter the spinal cord, and then gradually fiber from the upper part of the body join, right? So when the fibers from the upper part of the body join the system, they will push the fibers who are already in the system to the medial side. They push them to the midline, right? So that's how the sacral become most medial, lumbar become lateral to that, thoracic is lateral to that, most laterally located is the cervical fibers. So that is their position. I will talk about why understanding this position is important. It's very important, because if you have a lesion in the spinal cord, if you have a damage in this part of the spinal cord, the problem of sensation will be of the lower part of the body, right? But if you lose this part of the spinal cord, if you have a damage in this part of the spinal cord, you lose touch sensation from the upper part of the body, right? That's why it is important to know. Now, so we said spinothalamic, let's see. So they are calling it anterior spinothalamic, which is in the anterior column here. And this is the lateral spinothalamic. This is the lateral compartment, right? Lateral white area, anterior white area. And then again here also you see the most, but here is different. Sacral is the most lateral, and then you have lumbar, then you have thoracic, then you have cervical. Cervical is most medial. Now, if you have a damage in the medial part of the spinal cord in the lateral column, you will lose the pain from the cervical area. Whereas if it is dorsal column and if you have a problem on the medial side, you will lose the sacral area. That's why this spatial orientation or somatotropic map is important for you to understand. Okay. Now, so which means they will occupy different area. Spinothalamic will be anterior and lateral, and the other dorsal column will be in the dorsal column, which will carry fine touch and position sensation. Now, so look at this one. This will be important. Okay, I cannot see the whole thing. Okay, okay. So now look at this one first. So this is a touch sensation coming from the toe, right? If the touch sensation coming from the toe, if it is fine touch, you see it's a feather touch, right? So it is a fine touch, which means they will enter the dorsal column, right? Because they are dorsal column system. Now you see fibers are going up like this, and at this stage, you see the fibers from the upper part of the body is joining. You see, it's a same fine touch from the finger. So they are entering the spinal cord as well. They are also in the dorsal column, but which one is medial? Your lower part of the body is medial and upper part of the body is in the lateral position, right? Now they are going up in the spinal cord. When they go all the way up in the medulla, then you see these fibers, these are same fibers that originate from the receptor, still the same fibers, we call it first order neuron. So they end here in the nucleus because they need cell body to terminate, right? So where is this cell body located? This is located in the medulla, just above the spinal cord. So there are two nucleus we call nucleus gracilis, this one, and this one is nucleus cuneatus. Okay, so two type of fibers. From the lower part of the body they go to gracile nucleus, and from upper part of the body they go to cuneate nucleus. So the first order neuron end there. Okay, this is the end of first order neuron. The second order neuron begin from there at the lower border of the medulla. Now look at the fibers. This part is very important. The fibers here, they were on the stage on the same side, right? But at this point, after first order neuron ends, the fibers for the second order neuron, they are not staying in the same side. They are moving, crossing to the other side. Now they are going up on the other side of the brain, and then they reach all the way up to the thalamus. Thalamus is in the base of the brain here, thalamus. Now, in the thalamus, the second order neuron, which began here, they end here. And again, the nucleus is called VPL, ventral posterolateral nucleus. Okay. Now, the fibers of the second order neuron here, these fibers, the bundle of nerve fiber they form, they call medial lemniscus. Okay, medial lemniscus. Now, what area do they occupy in the spinal cord? Dorsal column. And the fibers are running in the medial lemniscus. That's why this system is called dorsal column medial lemniscus system. Okay, that's how the name came. Why it is called dorsal column system? Because they occupy the dorsal column of the spinal cord. Why it is called medial lemniscal system? Because they are second order fiber, they travel through the medial lemniscus. These two information you have to remember. Now, where the second order neuron is ending, the ending in the thalamus. Which nucleus? VPL, ventral posterolateral nucleus of the thalamus. So again, the second order neuron end here, the third order neuron begins, and they go all the way to the sensory area of the brain. Okay, so do you have any question up to here? Anything you want to ask about the way they came out? Now, are you clear about why it is called dorsal column medial lemniscus system? Because of two things. One is they occupy the dorsal column of the spinal cord, and medial lemniscus called because they occupy the fibers travel through the medial lemniscus. Medial lemniscus is just a bundle of fibers. They travel through medial lemniscus. That's why they are called dorsal column medial lemniscus system. What type of sensation they are carrying? They are carrying fine touch and position sensation and proprioceptive sensation, right? That is they are carrying. So now the fine touch of your one side is ending on the other side of the brain, right? If you lose this, if you have a damage to this side of the brain, you will not lose the touch from this side of the brain. You will lose the fine touch from this side of the brain, because this side of the brain, they are carried to that side of the brain, right? Now, where, at what point did they cross? They crossed, that's important. They crossed at the level of medulla, right? Where the first order neuron began. The axons of the second order neuron, they are the ones, they didn't stay in the same side, they moved to the other side. Okay? Because up to here, and as long as you are in spinal cord, these fibers remained in the same side. When they remain in the same side, you see, you will see we use two terms. One we say ipsilateral, the other one we say contralateral. When we say ipsilateral, we mean in the same side. When we say contralateral, we mean it is on the other side. Okay, so now the fine touch from this area or from this area, they end up on the ipsilateral side of the brain or contralateral side of the brain. Speak out. So I said fine touch of this area. Do they end in the brain on the same side or on the opposite side? This is the same side, right? This is the same side. They didn't go, they didn't go this side. They, at the level of medulla, they cross and they are going now on the opposite side, right? So how long they stayed in the same side? They stayed in the same side throughout the whole spinal cord at the level of medulla oblongata. I will take you to gross lab one day actually, so that you can see the real brain specimen. You can hold it in your hand. You can see the medulla and the pons and the. Will you be okay with those? You're okay, right? Okay, I will not take you to gross lab, so you don't have to worry about going facing the dead people. You don't. I will take you to 8th floor where we have isolated organs. You know, for the medical, our gross lab is in the basement where we dissect the whole body. So if you, I don't want, I will not do that. If anyone is interested to see any specific areas, we can have a demonstration. That's not a problem, but that is outside our class thing. But as we are talking about, see, we are talking about the medulla, we talk about the midbrain, we talk about the spinal cord, we say the sensory area of the brain. These are all theory. You are trying to understand it. You are trying to have a picture in your brain. But if you see that, if you hold the brain in your hand, you say, okay, this is the sensory area. You touch it, you feel it. That memory will last longer. That's why I want to give you guys an experience of those things. But I know I will make sure that you don't get scared actually with the gross lab. I will take you guys to the 8th floor where it will be only isolated brain, isolated spinal cord, isolated medulla. So you don't have to. But still, if any of you have any issues with that, let me know beforehand and just don't show up. That should be fine. And this is not something mandatory. You don't have to come. I just want to give you an experience of the holding the brain, spinal cord, midbrain, everything, so that you have a lasting memory. Okay, again, so we are talking about fine touch. We said fine touch, when they enter the spinal cord, which area of spinal cord they will occupy? They will occupy the dorsal column of the spinal cord, right? How many columns spinal cord has? Dorsal column, anterior column, and lateral column, right? Okay. Now, how long they remain on the same side? Up to the medulla, where first order neuron ends at the nucleus gracilis and nucleus cuneatus, and then at that point, first order neuron ends. Second order neuron does something very special. They moved to the opposite side. So that is now signal is not traveling on the same side. If they didn't move, they would have moved on the same side. But instead of moving on the same side upwards, they cross and they move to the contralateral side. They don't stay in the ipsilateral side anymore. They move to the contralateral side, and then they go up through the upper part of the medulla and the pons and the midbrain, and then they go all the way up to the thalamus. In the thalamus, second order neuron also ends. Okay, and where do they end? They end in the, we call it in short, we call VPL, Victor, like ventral posterolateral. And the ventral posterolateral nucleus of the thalamus, they ends, and then third order neuron begin from here, and then they go to this side. So fine touch of this side, end up in the brain of this side. So this side, we have to make it clear. We say fine touch will end up in the contralateral side of the brain. We don't have to say opposite side. And fine touch of this side of the brain will end up on this side, which is again contralateral for this side, right? Again, just the point that you really have to remember. Fine touch, they will occupy the dorsal column. They will go up, they will stay in the same side until the lower part of the medulla, where they will cross, the axons will cross to the opposite side, go to the contralateral side, and keep going up on the contralateral side all the way to the, so what are the relay stations? One is in the medulla, one is in the thalamus, and the third order neuron will end up in the sensory area of the brain. Okay, that's, so now let's move to the other one. Okay, let me move you guys here. Okay. So now look at this one. So this is thermal, right? Temperature or pain, it's the same. We said other type of sensation. What are those? Pain, temperature, and crude touch, right? Now, instead of being one like this one, they will be carried in two group of fibers. One group will stay in the lateral column here. The other group will be on the anterior column. The group that ascend to the lateral column, we call it lateral spinothalamic tract, because it's coming from the spinal cord to the thalamus, right? Spinothalamic, going up. Now, another set of fibers will end up here. What type of sensation do they carry? They will carry the crude touch, right? Crude touch. Okay. Anterior spinothalamic. Lateral spinothalamic will be pain and temperature, right? Pain and temperature. Now, look a difference on this one. Now, as they enter the spinal cord, they go directly to the cell body, actually, to the horn cells. Okay. And then they synapse there and move to the other side. In case of this one, dorsal column medial lemniscus system, crossing, where did the crossing took place? It took place in the medulla, way higher. But here, as soon as the nerve enter, on the same level, they cross to the opposite side. They move to the contralateral side. Okay, there is significance of knowing that, actually. So now they are ascending through the spinal cord on the same side or the opposite side? On the opposite side. Where did they cross? They cross the level at which they entered the spinal cord. Now they are going up. They cross only once, actually. They cross here and then they keep going up. They're going up all the way, and then they go all the way up to the thalamus. So which nucleus in thalamus? Again, the same nucleus on this, like this one. So we call it ventral posterolateral nucleus of the thalamus. So all sensory somatic sensation eventually will end up in the ventral posterolateral nucleus of the thalamus. We should be careful, actually. We should be technical. We should say almost all, not all. Okay, all. I will tell you why I just added almost, actually, just to avoid confusion. So almost all of them will enter the ventral posterolateral nucleus of the thalamus. From there, they will go all the way to the sensory area of the brain. Okay. Now, what is the major difference here between this system and this system? In this system, the crossing of the fiber took place at the level of medulla. Here, for the spinothalamic, crossing of the fiber took place in the same segment of the spinal cord where they are entering. Different one will enter at the different segment, right? But wherever they enter, Either they enter in the thoracic area or cervical area or in the lumbar area. As soon as they enter, they will move to the opposite side. Okay. So now location in the spinal cord is different. This is lateral and ventral. This one was dorsal. And crossing was in the medulla. Here crossing was in the same level in the spinal cord. But what is the similarity? Similarity is both of them, they end up in this thalamus of the other side, contralateral side of the thalamus, and they end up in the contralateral side of the brain. Okay. Now, this one will carry fine touch mainly. This one will carry pain, crude touch, and temperature. They are divided into two groups. Pain and temperature will stay on the lateral column. Crude touch will stay in the anterior column. One we call anterior spinothalamic. This one we call lateral spinothalamic, depending on the column, on their position in the spinal cord. Okay. Okay. Now let's move on. See. Okay. See, the reason I said almost all in the ventral posterolateral nucleus of the thalamus, I don't want to get into detail of this one, but our sensation from the face is not carried by spinal nerve. Until now, the nerve that we saw, they were spinal nerves. But the general sensation from the face is carried by a cranial nerve. I will talk about cranial nerve in one lecture. So cranial nerve, which cranial nerve will carry sensation from the face? It is called the trigeminal nerve or fifth cranial nerve. Okay, trigeminal. When we say trigeminal, it gives us an indication that it has something three related to it, right? Trigeminal, because this nerve has three components. You can say three divisions. Okay, division number one, we have division number two, we have division number three. Okay, so we don't say this one has a name, we call it, you don't have to worry about this one now. I will talk about the cranial nerve later. This one, V1, we call it V1, V2, V3. V for what? V for trigeminal. Why we say V? Because it's the fifth cranial nerve. Okay. V1 means first division of fifth cranial nerve. This has a name actually. It's called ophthalmic division. This is called maxillary division and mandibular division. These are the three divisions. Okay. Now, if every time I say the ophthalmic division of the trigeminal nerve, mandibular division of the trigeminal nerve, that will be a problem, right? It's not easy. So we say V1, V2, V3. When we say V1, I mean ophthalmic division, and then maxillary division, and then mandibular division of the trigeminal nerve. Now, the point that you need to remember here is that this general sensation from the face, either it is fine touch, crude touch, pain, temperature, all is carried by a cranial nerve. Which cranial nerve is it? Fifth cranial nerve called trigeminal. Okay. And one thing that you have to remember about the difference, do you remember last time when we talk about the sensation from other part of the body, which nucleus did they end up in the thalamus? It was ventral posterolateral nucleus of the thalamus, right? In the thalamus. Now, in the case of this trigeminal, they are ending in the thalamus as well, but the nucleus is different. This is ventral posteromedial. Ventral is same. It's a ventral nuclear complex in the thalamus. One is posterolateral, one is posteromedial. Posterolateral was all the sensation from all part of the body, and posteromedial is the sensation from the face. Okay, that's all. I don't want to get into complication here. Now here you can see the V1 does this area, V2 does this, V3 does this. This is called the mandibular division. This is called the maxillary division. This is called ophthalmic division. Ophthalmic division because this contain eye here, right? And this V2 called maxillary division because this upper jaw, this bone is called maxilla. We call it maxillary division. And this bone where we have the tooth of the lower jaw, this bone is called mandible. We call it mandibular division of trigeminal. Okay. Now, dermatomal map, I don't know whether you need to know. You see, it's like this. There is a map here, right? V1 this area, V2 this area, V3 this area. Like the whole body has a dermatomal map. So if we say T7 here, which means the sensation from this part of the body is carried by 7 thoracic nerve. The spinal nerves are divided according to region. We say cervical, thoracic, lumbar, sacral, coccygeal, right? You don't have to worry about those. But know that there is a dermatomal map actually. A part of the skin that is innervated by that particular nerve is called the dermatome. We say this one is T10 nerve, dermatome. T10 dermatome is important because this is the area of the umbilicus. T5 dermatome is another important landmark because this is the area of the nipple. Okay, in between, so if you say T5 here, T10 here, then you know the rest of them. You don't have to memorize all of them, so you know gradually how they will change. 5, 6, 7, 8, 9, 10. 10 is another big area, is the area of umbilicus. Okay, and like this one, this is V1, V2, V3, like more like a dermatomal map. Now, so when the information is carried into the brain, okay, so now let's see, show you something. So all the sensation of the body eventually end up at an area in the brain we call primary sensory area. Okay, primary sensory. This fissure divide the brain into on the front you have a frontal lobe, on the back of it there is a we call parietal lobe. Okay, so now this is the area all the sensation will eventually come here. We call it primary sensory area. You can see here, this is the primary sensory area here. So all the information from all part of the body, if it is sensation, they have to end up in this area, primary sensory. If they end up here, this is the motor area. If you bring all the sensory area and dump them here, you will not feel any sensation, because this part of the brain is not equipped to analyze or to give you a conscious sensation of sense, a sensory information. This area is designated for motor information. So do you remember we said labeled line principle or the principle of specific nerve energy? So if it is a sensory information coming from any part of the body, they have to eventually end up in this area. We call somatosensory area 1. Okay, and there are some additional areas as well called, somatosensory area 2. But this is the primary somatosensory area. All sensation from the body will eventually, from the thalamus, we said from the thalamus, it will go to the brain. Which area of the brain they will end up in? We call it primary sensory area. Okay, all sensation is interpretation of sensation is done in that part. Now, another important thing is that, this area, the represented in the brain is not dependent on the size of the part of the body. Okay, rather, which part you do fine function. Like as I am talking, you see how many things are moving, right? My tongue is moving, my larynx is moving, and very fine movement. You are writing, you are playing piano, very fine movement, but you are walking, running, they're not very fine. You don't do very fine movement. So now, depending on how precisely you need to have a sensation from an area, depending on how delicate function is performed by that particular area of the brain. Okay, now for an example, I don't have to talk much, let me show you. Now, see, the face is represented by this much area of the brain. Okay, from here to here, it's all for face. Signal from the face is coming here. All signal from face. Now, compared to, look at hand here. Hand occupy this much of the area. Now, look at the trunk. Whole trunk, this is the whole body, right? Trunk and thigh, this is the major volume of the body. They occupy this much. Okay, so not all the area is represented in the brain in the same, or the same area of the brain is designated for that area. A big area is designated for face. A big area is, look at the index finger. It's separated here because you do a lot of fine things here. You are writing, you are playing piano, do things, fine things, right? So that's why you need a lot of nerve supply here. But you don't need that much. That's why if somebody touch the skin of your back, and then if the 2 point of touching is this much apart, you don't even cannot separate. You see, somebody touch the skin of back of my neck. But if this much somebody touch your cheek, or or tip of your finger, exactly where the touch was. So that, because that is represented in the brain by a bigger area. That is called the homunculus. Homunculus is a small man, right? Small man. And look at the unequal distribution of the area in the brain, right? Hand is represented in the brain by this much, but whole, your thorax, abdomen, your trunk, and your thigh up to your leg is this area. Same as your hand. If you look at, compare how many hands you will have in your trunk, and you're up to, all the way to the knee. It's the same area, represented by same area in the brain as you have the area designated for the hand. So this is called, you see a human being, you can see here. Now look at the legs are on the medial side. You see the brain, two sides of the brain, they fold like this, right? Two cerebral hemispheres. You will see, actually, when you see the brain, you will see, if you open the brain here, there are two cerebral hemisphere. So it goes from the lateral and then go to the medial side. Now look at this one. The leg is represented by this area of the brain. Now why it is important for you to know? Because see, you hear about stroke, right? Stroke is either rupture or blockage of a blood vessel in the brain. So equivalent term in the heart, we say heart attack. You see, heart attack. And the stroke, some people call stroke a brain attack, because see, like you have blood vessel going here and blood vessel going here, blood vessel going here. See, if you look at the blood vessels, a lot of blood vessels, right? Okay. Now, if you lose this blood vessel, if somebody has a stroke that block this particular blood vessel, do you think you will have any problem in your legs? No, because even though it's a stroke in the brain, but you have to know which area was in trouble. The area was in trouble was this part of the brain. So which part, the sensation from which part end up in this area? From face. So you will lose sensation from the face from that particular stroke. But if somebody has a stroke around here, so this blood vessel is blocked, either it is blood vessel is severed, is damaged, or it is completely blocked by something. So no nutrition is going to this area of the brain, which means this area, cells of brain in this area will die. So what type of area will lose sensation if you have something like this? Your legs, like your feet. That's why it is important for you to, you don't have to memorize completely, but you need to know that the face, or the lateral side will have at the bottom, you will have abdomen, the tongue, pharynx, and then you have big area for the face, then you have hand, then you have trunk and legs. And on the medial side, you have the lower part of the leg and your feet and the genital organs. They are all here. Okay. So that will give you an idea of which brain is receiving signal from which area of the brain. So if any damage to that particular area, you will lose the sensation from that particular area of the brain. And most important thing that I want you to appreciate here is that not all area are represented in the brain depending on their size. It's not their size, it is how precise an information you need from a particular area of the brain. Okay, because you see, if the muscles of larynx, if you look at the muscles of leg, they're these big muscles, right? Now they are represented in the brain by the very small area, but the muscle of the larynx, the one that is making me producing sound, is this tiny muscle compared to that muscle. Maybe if you compare the muscle of the larynx with the muscle of the leg, it will be, I don't know, maybe 1,000th part of, maybe if you put the muscles of the larynx and multiply it with 1,000 or 5,000, that will be similar to a muscle of the leg. Okay, but you have this much area in the brain for the muscle of leg, you have this much area for the muscle of the larynx, because you are making those people who sing, right, the nice voice, they can change their voice, different voice. So you see, this one, this muscle here is 2000 times bigger than this one. But when you go to the brain, this muscle is represented by this much area, the big muscle is represented by this much area. Because with the leg muscle, what do you do? Anything? Fine. You run, you walk using those are important. Those are important, absolutely important, but you don't do anything fine actually with those. That's why they are represented in the brain with a small area. Okay. Now, this one is whatever we talked so far, this one will give you an idea of that one. If we have a lesion, right? Now, if you cut all the nerve fiber of this side of the spinal cord, okay? We call it hemicord. Hemicord means half of the cord, right? Now, if you have a damage to the spinal cord of this area, so you will lose the fine touch of the same area because they were on the same side, right? But the pain of this side traveling through this side. So you will lose some pain, some touch of the same side, but pain of the opposite side. Because when you cut this fiber, you are cutting the pain fiber of this side, but fine touch fiber of this side. Did you get that much? Again, a few things about the tract you have to remember. Which tract is carrying what type of information? That is absolutely important. And then what is their location in the spinal cord? Which area in the spinal cord do they occupy? Based on that, we name them. We call one dorsal column, medial lemniscus system. The other one we call lateral spinothalamic tract versus anterospinothalamic tract, right? So now we have to know what is their location in the spinal cord. And then number two, we have to remember at what level the fibers move to the opposite side. For fine touch, it moved to the opposite side only in the medulla of the brain. Okay, they in this, as long as they are in the spinal cord, they remain on the same side. So they move after the first order neuron ends in the medulla, and then second order neuron move to the opposite side. You see, in both cases, second order neuron will move to the opposite side. And then where do they relay in the spinal in the thalamus? In the thalamus, they relay in the ventral posterolateral nucleus of the thalamus, and they go to the brain of the same side, but opposite to where the signal initially originated. Now, for the spinothalamic, which area of the spinal cord do they occupy? Either lateral or ventral area. That's why we call ventral spinothalamic and lateral spinothalamic. What is the difference? Ventral will carry crude touch. Lateral spinothalamic will carry fine touch, the pain and temperature. Now, where do they cross to the opposite side? On the same level. Whenever they enter the spinal cord, they immediately cross to the other side. So you see, their first order neuron ends here. In case of dorsal column system, where the first order neuron ended, first order neuron ended in the medulla. But in this case, first order neuron ended immediately as soon as they come, and the second order neuron cross to the opposite side, and then they stay in the same side. So always whatever the signal is, if it is pain, touch, temperature, they all will eventually end up in the opposite side of the brain where the signal initially originated. But at what level they will cross the side will determine on what tract we are talking about, right? If we are talking about the dorsal column medial lemniscus system, they cross at the medulla. If we talk about spinothalamic, they cross at the same level where they enter the spinal cord. Okay, and both of them, they will eventually end up in the ventral posterolateral nucleus of the thalamus, and they will eventually end in the sensory area of the brain. That is the end. Now it is brain's function to interpret that signal and give you a conscious sensation. Okay, only difference from the face is that they will also end up in the other side of the brain, on the sensory area, but they are carried not by the spinal nerve, they are carried by cranial nerve. Which one? It's a trigeminal cranial nerve number 5. And in the thalamus, they are little different. The other ones, they end in the ventral posterolateral nucleus of the thalamus. In case of face, the trigeminal system, they end in the ventral posteromedial nucleus of the thalamus. Okay. I think we are done. Well, I didn't talk much about the real things, right? We talk about some basic issues that took about half of our time. But I want you guys to have a very clear understanding of what is membrane potential, resting membrane potential, what is an action potential. But as I said, you will not be tested on that. But just to know that what are the, and then sensory tracts are also called ascending tracts because they are carrying signal up. And the motor tracts are called descending tracts because they will carry signal from the up to the bottom, right? Say as I am moving this muscle, where is the signal coming from? Coming from the brain, right? Coming from the brain to the spinal cord where the nerve is going to this muscle. So this signal is downward, going downwards. A plan was done in the brain and then it came here to the spinal cord and moved my arm. So we call motor tracts, we call descending tracts. Sensory tracts, we call ascending tracts. Okay, ascending tracts or motor tracts, descending tracts or descending or motor, ascending or sensory. Okay, I think I don't want to talk anymore. That's it. If you have any question, you can tell me. We can talk a little bit. Is it something? Did I give you too much information? It's okay, right? Real information was not much though. Real information was last 30 minutes. First 45 minutes was not necessary. You know, it was just to background information. Okay. So, but then, so, and also, even if you don't have any question at this point, but if anything come to your mind at any time, feel free to send me email. I check my email on my phone, so I will immediately get it. Or if you want, if for email, maybe I may not look at the phone maybe for half an hour or an hour or so. But if necessary, if email doesn't work very well, you can send me text message as well. And did I give my cell phone number on the syllabus? I don't know. If not, then my cell phone is 837 2743, and it's Little Rock, so it is 501. Okay, let me write it. Oh, I'm getting better on writing on this one, right? It's 501-837-2743. As I said, you can send me email, you can send text message, but if you want immediate attention that I don't want you to even give you a time to look at the phone for text message, you can even call me. And you can do whenever is convenient for you. If I am in a class or in a meeting, I will not be able to receive the call at that point. But if I miss a call, I will call you as soon as I can. You know, so if you have anything come to your mind, don't let that bother you and then affect your experiment, affect your other study and all those things. So whenever anything come to your mind, reach out immediately. Okay. I believe I have to look at the schedule. I believe next class will be your chemical sensation, a taste and smell. Dr. Abdullah Hayar will do it. I will send him the Zoom link, so you can join this using the same Zoom link as well with his class. Okay. So if you don't have anything, thank you so much for joining this class today. I will see you guys next time. Okay, when we talk about the cranial nerves. Okay.
I just
Thank
have a
you.
quick question, Dr. Syed.
Yeah, you have a question?
Yeah. So
Yeah.
I know you mentioned that
A little loud, please. Yeah, can you talk a little louder, please?
Sure. So can you hear me better now?
Yeah, I can hear better now.
So I know you mentioned that you're recording the lectures. I was wondering if it was possible to post them on Blackboard or on the course websites. That way we just always have access to them.
Okay, so see, regarding that, let me tell you something. I am recording them just in case, if
Okay.
somebody need it. Okay, but I just don't want to make it a routine that I put all of them on the black. I can embed those videos on the blackboard if you want to, anyone.
Mhm.
But these are my ones. I can do it, but I will record other faculties' lectures as well. But to put them on Blackboard, I need to have their permission. Okay, so I will ask them permission. I'm pretty sure no faculty will say no to any student. But of last 3 sessions, if you need anyone that you want the recording available to you, let me know. I will post it on the Blackboard. But
Okay.
that I want to do on demand rather than it's as a regular practice. But I am preserving those recordings. So if you need it at any point, don't hesitate to let me know.
Okay.
Okay, did you get it? Thank
Thank
you.
you.
Thank you.